You all picked up your little heart to carry your aspirin. You may just wind up saving a life. I've used it one time. Actually, it wasn't for a cardiac arrest or a heart attack. My son's basketball high school coach was teaching him how to take a charge, and one of the kids panicked and really hit the coach hard in the groin with his knee, and the coach doubled over, and I rushed to the scene and gave him 4 baby aspirin, and he was immensely thankful. I did a STEMI yesterday afternoon. I just happened to be walking past the emergency room when somebody had one, and it was a young guy, 58, with no other medical problems. He took an aspirin as he drove himself in, and I'm taking the history and quickly examining him as we're tabling him. He was in moderate discomfort. It was an LAD, big ST segment elevation. I was telling him, things are going to move very fast. We're going to walk you through this. And at the end, he was pain-free and he's feeling fine. And his comment to me was, "Doc, you were right about the urgency. I've sat waiting for a haircut longer than that." So when the systems are working well, it can work very well. What I'm going to do is repeat a lot of the things that you've already seen. I think repeating issues like this is very important because we have important messages we want to do. Let's see, go up here to play. So this is kind of our map, all of our hospitals. It's kind of the same map we used back in 2009 when we had our first conference. And I too have zero things that I have to say I'm getting paid for. Maybe dinner tonight, I guess, ought to count. That's about it. What do we want to do? We want to get the individual with the acute STEMI by either air, walking into an emergency room on their own, or by ground transportation to either the cath lab or to thrombolysis in as fast and as safe a time as we can. Less of an issue here in the city for thrombolysis since you're well covered. A little bit more out in the far reaches of Bend, Oregon, where Mike and Bruce and I are from. But nonetheless, lots of options. This was our goal back in 2009. We kind of had set aside, and a lot of these things are very similar to what Mike Widmer said in his opening slide. STEMI, as you've been hearing, is an extraordinarily solvable problem. In fact, there's no reason why it shouldn't be solved right now everywhere, and all we're doing now is refining it. But there are very unique regional issues, and it depends on logistics and geography and politics and resources and finances and local champions willing to step up and having protocols that are constantly evolving and developing solutions and working collaboratively with all the elements that you keep hearing over and over and over. EMS does drive this system. You need them to kind of be on board, start the process, and alert the entire team ahead of time. And then in the long run, data drives change, and the KISS principle, keep it simple, stupid. If you make it too complex, it ain't going to work. This is my own variation. I've been in practice now for 31 years in Southern Oregon and Medford, but in the 1970s, okay, when I was in med school, the death rate from myocardial infarction was 25 to 30% for a STEMI. When Grandpa went into the hospital, 1 time out of 4, Grandpa never came home. People didn't even talk about heart attacks. I mean, it's like cancer. Oh my gosh, don't tell the patient because they're going to die. Then they developed coronary care units in the in the 1970s. First one's probably in New York City and in Ireland in the 1960s, but that helped. It was basically a single oscilloscope with a curtain between a GI bleeder in one bed and a guy with a heart attack in the other, but a few of them would have a heart attack and you could shock them and they would survive it. And the death rates dropped to about 15%. And then in the 1980s and 90s, and now in many places around the country, thrombolysis came aboard. And thrombolysis works. It works well. It dropped the death rate anywhere from the best of hospitals, about 7% up to 12%. And then, at least in Southern Oregon and Bend, and now most places around the country, and you've seen the statistics nationwide, you can get the death rate down to in the range of 3 to 5%. That is an incredible impact on mortality. But treating a STEMI in metropolitan Portland at rush hour has a few different hurdles than Eastern Oregon at sunset or during the winter. Total different mix. There's LA, I suspect. Where is that, Ivan? It looks awful. But the challenge is, how do you bring all of these regional logistics to control and seamlessly move them safely and rapidly from one location to a STEMI center or to an emergency room? And if everybody's not working together, you've got the headless patient up there. It doesn't do any good. This is my favorite quote from Ivan. It's appropriate today, probably not as appropriate as it was when you first came up with this in the mid-2000s. But basically, he says, it gives you chills, primary percutaneous coronary intervention is the most complex, multidisciplinary, and time-sensitive therapeutic intervention in the world of medicine today. The process is measured in minutes, the outcomes are measured in mortality, and teamwork and smooth transitions are absolutely essential. And I think, Ivan, that is well said, and it's true. And we've gotten better at it, but it doesn't take much to derail it. So what do we have out there? Well, we have thrombolytics, which work and are good when you're in distant places. And my favorite thrombolytic is stainless steel or cobalt chromium. That works very well too, even better. When I first got to Medford in 1982, I was working with Ward Kennedy, and we were doing the Western Washington study, where you never, ever, ever, ever at that time did an angiogram on somebody who had had a myocardial infarction. You had to wait 6 months. And Ward took streptokinase, and we didn't give it intravenously. You gave it via the catheter. This was my very first patient, my very first day on call, an acute inferior wall infarction on a 42-year-old fella. And you can see the myocardial infarction. He's got a right coronary artery that is completely blocked right in its midsection, and he's hypotensive, he's bradycardic, he's nauseated, he's puking all over the place. And we had 1.5 million units of streptokinase, and I would push it in 1 cc at a time over an hour. And after about a half an hour, I took a picture, and the dye would go down. It would just stain the clot, wouldn't go through. And then after about an hour, the dye went through. And this was, if I show this at Cath conference now, you'll be run out of town. This was phenomenal. We didn't even know what heart attacks were because nobody was studying them. And this opens, and it clearly saved lives. Now, the door to drip time was on the order of like 3 to 4 hours from the time they'd come in. By the time you went through, all the consenting and you dragged the cath lab in, we don't do those, do we? I mean, now it's measured literally in minutes. It was measured in hours. But that was a resounding success as the drug, basically broke apart all of the stuff and the blood could flush on down the artery. It didn't take more than 2 or 3 more red blood cells to clog it back up again, but it worked. Compare that to what happens in acute intervention, where you have an acute proximal LAD widow or widower maker and balloon stenting, and that's what you get most of the time, and time is of the essence. So lots of studies with balloon angioplasty. Most of them were small studies. Nobody had systems of care, but you would get a couple people would publish it, and when they tried to randomize people into thrombolysis or balloon angioplasty or balloon stenting back in the 90s and early 2000s, this is what you found, that no matter what metric you used, balloon stenting won. The problem was that most places didn't have the logistical capability to pull it up because they did not have the systems of care to get the follow-through. It was a best practice, however. It was the roots of a best practice. Here's one article from Circulation. The blue is transfer for PCI, percutaneous intervention. The reds are on-site fibrinolysis. No matter what you look at, whether it's death or MI, death, MI, or stroke, PCI wins. And it wins by a lot if the systems are in place. Another best practice reassurance. We have the Oregon Trauma System, and some of you in this room know a lot more about that than me, but it is a framework within which we can get some of these regions of care. Rather than hospital-based, they are regional-based, and they're based on logistical and geographic issues. And we have in this town, and we were talking about what you have in LA, I don't think we even begin to approach it in our state, but we have 191 non-transport responders and 134 medical EMS systems. So a lot of individuals, and you know, some of these are basically Boy Scouts with first aid capability. I mean, they don't have 24/7 paramedics with full EMT3 training like you have in LA. So you have different expectations of being able to recognize an infarct, and then where are you going to take them? You'll notice the really huge area over here in Central Oregon, which our friends from Bend have done a great job you know, covering that whole area. A lot of helicopter transports and stuff all in there. My area is down in there. So here is our regional center. We started off with 2 cardiology groups that became one, and we had a mission statement that we started in 2003, and it was basically to get folks an accurate, rapid, and safe diagnosis of STEMI and get them to the cath lab and get them open. We had an interventional hospital and 4 other hospitals on the I-5 corridor within 2, 12, 32, and 52 miles, and they were there. One of the hospitals has their own program now, the Providence Hospital. They have their own. We also had 8 different paramedic units and first responders in our region. And then we had 5 other hospitals in the area that were too far for immediate transfer, but would thrombolyze, and then they would air transport to us by either fixed wing or helicopter. And that's been in place since 2003. Similar on a much smaller scale than our North Carolina colleagues. Here was the article that you saw that Ivan had published before. We were part of that, and basically he was right. People back at this period of time in mid-2000s, oh, it can't be done. It can't be done regularly. And this article said, oh yes, it can be done, and it can be done in small places, big places, medium-sized places. You need a system of care to pull it off, and you can pull it off. And what happens is you can have 86% of the folks less than 90 minutes, 50% less than 60 minutes, 25% less than 45 minutes if you activate from the field. And you can even get 68% of them with the emergency contact to balloon. It can be done. So the no-brainer best practices, these checklists, this was kind of pirated from that New England Journal by Bradley and Kumholtz. And it's been modified. This is much of it, people add a little comment here, take a little comment. Most of it is cooperative effort. And you can read them as well as I, but basically the pre-hospital electrocardiogram, as far as I'm concerned, is the major factor that permits the shortest balloon delivery system, and also has the lowest death rates associated with it because it's the fastest time. It's faster than walking into a PCI hospital. You walk into a PCI hospital at 8 o'clock at night and the cath lab team isn't there, it has to be mobilized. You activate 25 minutes from us while the paramedics are coming in, the cath lab team is coming in, and you just seamlessly go right into the cath lab. So there's Ivan. You need champions, okay? You need champions at every stage. You need champions in the emergency room. You need champion of the entire group. You need champions in the cath lab and champions at each of the other hospitals. And everybody is part of the team. Nobody is allowed to say, not in my job description. There was a lot of pushback early on. Oh, we can't do this in the emergency room. And you know, my comment I make, if a plane crashed at Medford International, would the emergency rooms of Providence Hospital and Rogue Valley Hospital turn them down? Of course not. They would mobilize and do it. STEMI's one patient at a time. And we're taking them off your hands. Like you said, they're not going to be sitting there consuming your nurse and all your laboratory data. We'll take them. We're blessed. Tomorrow, we're having Dr. Patrick O'Gara come. Here's the fellow who's going to be the upcoming head of the American College of Cardiology, and he is the chair of the guideline committee. These were just published in January 2013. So we have lots of resources that we can rely on, and the American College and American Heart are committed to, you know, they update these in 1999, 2004. There were focused updates in 07 and 09, and then the most recent ones in 2013. And you've seen this Ivan presented this. This is the pathway for how to get from your STEMI chest hurting to getting an open artery, one way or the other, preferably by PCI. The issue that you've heard every speaker talk about, this is an issue. The door in, door out, less than 30 minutes. It's very difficult to achieve, but what is it, 11% of people get that. You know, I think 40, 45 minutes is reasonable, 70 minutes is not. And this is an opportunity for a best practice. Everybody should be working on that. And we have resources of, obviously, the Mission Lifeline, which is not just the door-to-balloon initiative in the cath lab. It's that whole system. How do you educate the patient? Isn't it amazing? Every STEMI patient I see these days has popped a couple aspirin before the paramedics even get there. The education gets out there, and it can be done, and now we just have to tell them when you have that discomfort that's not your usual heartburn, don't sit on it for 2 hours before you call 911. Now, some of the challenges that I think Fred's going to run up against and others are everybody's using different metrics. All of these systems were kind of put together. The Bend had a system, we had a system, Ivan's got a system, North Carolina has a system, and we use different criteria for what we would use. They recently just published third universal definition of myocardial infarction states new ST segment elevation at the J point in 2 contiguous leads greater than or equal to 0.1 millivolt in all leads other than V2 and V3. So they're giving you 1 millimeter now in V1, okay? And it'll be 0.2 millivolts in men greater than or equal to 40 years of age. Oh, but wait a minute, if you're under 40 years of age, it's 0.25 millivolts, but if you're a woman, it's down to 0.1. The KISS principle seems to be lost, okay? That's a lot to ask the paramedic out there to see half a tiny little red box. And I've checked with Zoll and I've checked with Physio Control about this. These were published. When is that going to change to automatically pop up as star, star, star acute MI? It's not operated yet, unless maybe you know differently, but it is not. It has to go through all sorts of FDA stuff before that becomes operating. So I'm a little concerned about that universal definition. I saw that I was reading the STREAM trial, and the STREAM trial was using 2 millimeters in 2 contiguous all leads, not 1 in the inferior lead. So people are using different definitions. Recognize that can lead to false activations or underact. If you say, I'm only taking people to the cath lab with 5 millimeters of ST elevation, you're never going to miss one. At least you'll be accurate all the time. However, you will miss an awful lot of people who had lesser degrees of STEMI. The J point, which you can see down there, is great on paper. It's not always quite so evident. There's a pretty easy one to see, and sometimes they're a little bit harder to see. You have the advantage as a treating physician or nurse in the emergency room. The elephants on their chest, they're nauseated, they're pale, and they're sweating. The EKG machine doesn't always necessarily have that criteria. And then there's these additional challenges that you have to wrestle with. Real-world EKGs have left bundles. They have rapid atrial fib. There's posterior wall infarctions. When they developed the electrocardiogram, they never quite thought to put the leads back here at 7, 8, and 9. You have to peel them off and put them there. And it hasn't changed, at least not in official guideline criteria. Acute left mains, look at AVR, a lead that we always ignore, but if you got it elevated in AVR and it's depressed in 5 or more or 6 or more leads elsewhere, you've got a left main or a severe triple vessel disease, and then the right-sided infarctions. So these are kind of some important issues depending on how strong your EMS system is. If you're in remote Eastern Oregon, you're not going to have a full team of paramedics. You're here in Portland, you're darn well going to have all those folks. And the paramedics will, and even the ER physicians and even the cardiologists are very much influenced by star, star, star acute STEMI. Once that appears on there, you can overread it and say no, but it's very hard to overread. Oh yeah, this is clearly pericarditis. Sure, if you heard a rub and the person's 18 years old and they got a driveling, snotty nose, yeah, you feel comfortable. But when you're 42 and you have an EKG, I've seen a lot of acute STEMIs that look like this kind of ST segment rather than that. and it kind of sets things into motion. No IV drips, you've heard that before. Does the macrame in the cath lab really get complicated? Okay, if you really need it for blood pressure, fine, but if you give a bolus of heparin, I don't need a drip, okay? I'm gonna have the artery open long before the bolus of heparin has worn off. So paramedics can activate in the field, and our paramedics are empowered to use primarily the star acute MI, but they have the advantage of looking at the patient, getting a quick history, and they are permitted, if it's not called on the star, they can activate it themselves. There's other systems where the paramedics will activate from the field only after they have faxed the information into an emergency room or a cardiologist. And then there's other systems where basically they will be triaged to the closest hospital or to a STEMI receiving center for the assessment to take place on site. I have a couple, these are some pocket cards we have, and take a look at some booklets for emergency rooms, and some ER posters that we put together and we modify. And basically the average paramedic may see 1 or 2 STEMIs a year. That's all. The ER doctor may see 5 or 6. Okay. Cardiologist may see 12 to 30. So it's kind of hard to keep these constantly changing guidelines at the forefront. So what we did is we developed a little pocket card with indestructible stuff. You can't rip it. Paramedics tried. They cannot rip it. And we have cards for you. Go ahead, try. We tried, we have ones for EMS pockets. We have one for cardiologists. On the cardiologist card, I have all of the phone numbers of the referring hospitals. I have, for that very, very, very rare situation, a TNKase dosing or a TPA dosing, which I don't use anymore. And, it's easy now with electronic records to probably pull it up, but it's just so much easier. There it is. I got it. We have it for the cath lab team. We have it for the ER physician. We have it for an ER physician who's going to transfer for immediate PCI. We have it for an ER physician who's going to thrombolyse, and it's just boom, boom, boom. Here's the number to call. Here's the number. Same numbers on the back, no matter which way they open up the book. And these can be modified however you want. We try to update them according to the guidelines. So this is an article that was just came out in December. I said, wow. We've been noticing this for really quite a while. It just says that pre-hospital triaged patients achieved the 90-minute door-to-balloon time benchmark 80% of the time as opposed to 8.7% of the time. That's a highly significant number. But probably more impressive than that had a significantly lower 30-day mortality, 5.4% versus 13.3%, because they get opened quicker. It's a best practice. Here's our data from walk-ins to our 4 STEMI hospitals between 2003 and 2008 versus walk-ins to our PCI center versus EMS directly triaged from the field directly to the cath lab. That's a pretty significant, though. That's in-hospital mortality. So the best practice is activate in the field if you've got responsible paramedic teams and go right to the cath lab. We use the metrics horizontally. These are our own homegrown ones. We'll probably be changing over to action and make them vertical, but it shows the same stuff, okay? It shows the blue is the time on scene. This happens to be an EMS. We can do this for every hospital, every doctor, every EMS system. This is an EMS system looking at the contact, emergency to balloon contact, June 2003 through July 2010. And so we got time on scene. You can see that's pretty constant. It's 15 to 19 minutes. That's not going to change very much. The time on the driving isn't going to change very much, depending on whether at the far end of the county for their 2 or 3. You can see the totals were, good numbers for each of this EMS system each year. The yellow is the time in the emergency room. When we first started our program in 2003, we were a little apprehensive about taking the paramedic activated directly to the cath lab. So we said, you better come to the emergency room. Look at what happens when you come to the emergency room. We said at the end of a year and a half, we looked at our false activations, we said, doesn't make sense. They're doing a good job. They're doing as good a job as the physicians in the emergency room activating it. Let's get rid of the emergency room as an obligatory point and look at, we're now down to here. Now, you got after-hour visits where they're close by, so, I mean, the cath lab crew isn't in, or maybe they're really super unstable with arrhythmias, so you don't take them right to the cath lab, but you cut the time and look at the effect it had on the door-to-balloon time. Take them directly in if you trust the information coming from your paramedic teams. Because the time in the cath lab, well, we've gotten a little bit better. The bigger thing was the time in the emergency room at the STEMI receiving. Now, there's an awful lot of doors, and not everybody's door is the same. When you start comparing, you know, oh, my statistics are better than yours, make sure you're talking, you know, some people, you're talking about time the EMS arrives on scene, or is it the time that the call went in? I mean, it's a system response. Is it emergency room getting the EKG, rather the EMS getting the EKG? Is that the time the clock starts? Is it the door to EKG when they get to the hospital, the door to groin? Some people don't really, they just talk door to groin, door to balloon or device, door to needle. I pulled from the guidelines, this was from the 2013 guidelines, this is kind of the terminology they'd like to do from door to EKG, EKG to cath lab or EKG to needle, and cath lab to device. And that helps you with each of the team members where you can then decide there might be room for improvement. We even put up, our cath lab is located a distance away from our emergency room. It's rather circuitous to get there. Our paramedics maybe only see 1 or 2 a year. We put up these big red signs from the ambulance bay. Go to the end, turn right, turn left, turn right again, then you're in there. We had a couple cases where they would get lost, and we built the signs. It's a best practice. These are pretty self-explanatory. Obviously, PCI, primary PCI is the recommended therapy. It's a 1A if you can get there quickly. Regional systems of care are very important. Okay, 12-lead EKG by EMS if you've got teams that can do it. Very important. EMS transport directly to a PCI center. And then if you can't and you're over 120, although I would have to say, these are the goals. I think as we look at all the data that's been presented, most people are over 120. Most people are over 120. And we still have good outcomes, but we need to keep pushing it down because I think it's very important. These are basically the ER poster that will have, you know, how to activate the system. What's the number to call? First thing you do if you're at another hospital, okay, is get a transfer underway. That could be the limiting factor. We're going to take them. We are never closed to STEMI. Call the paramedics, then get the cardiologist. Cardiologist will say yes. If the cardiologist isn't available, is in the middle of a tough case, the ER doctor will say yes. These are the ER physician pocket cards for immediate transfer. It's got all the numbers that they might want to have there. It gives them what we consider to be the immediate activation, get the process rolling. We have it for a pocket card for them if they're going to be doing thrombolysis, and it has the doses of the various medications that they would be using. All cookbook, boom, 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 right there. It's on the poster, it's on the pocket card. Now, there are unintended consequences of this shortening of door to balloon. Make no mistake about it, okay? People are rushing, we're getting better and better and better, and yet at the same time, if you rush too much, you can miss dissections, you can miss pulmonary emboli, you can miss pericarditis. So we have a problem, and CDR is going to help us solve this, I'm certain. Here's an article published in the Archives of Internal Medicine, and I can't quite tell. I saw an article that I brought with me that said this was 2 Boston hospitals, and another one said it was 2 San Francisco hospitals. Physician ER activated STEMI. 36% of the patients did not have an infarct-related artery, even though they were activated as if they had a STEMI. 1 out of 3. The hospital administrators are going to take a look at that. Now, I'm not saying that's bad. I would tell you that probably shortens the hospitalization of the patient. You find out they don't even have heart disease. They don't get the cardiolite study, which is inconclusive, sitting around for 2 days and get the heart cath anyway. But it's not a number that anyone would be proud of. And then here's one from the University of Michigan. Look at this. they had in 2007, their average door-to-balloon time was 73 minutes, and they pridefully and very nicely got it down to 64 minutes. And look at what happened to their false activation rate. They did not find an infarct-related artery. Went from 23 to 48, 1 in 2. Ouch. Now, they very nicely showed that. They were willing to share that data. I guarantee that's happening in a lot of places. And CMS data from 2005 to 2010 showed that numbers of door-to-balloons did drop, but mortality didn't seem to change very much. You know, it's hard when you get the mortality down already pretty low. It's hard to make a bigger dent in it. It's an opportunity, however, for a best practice. The STREAM study is important probably for some of our more rural residents. This was basically if you arrived at an emergency room within 3 hours of the onset of your STEMI, but you would be at least an hour or more before they could do PCI. They randomize them. You get PCI, you get tails, you get thrombolysis, and then you get sent over. And it turned out that over a third of them, even though they got thrombolysis, over a third of them, even though they were there within 3 hours, didn't reperfuse. Their STs didn't come down, chest pain continued. They had to have salvage angioplasties, emergent. Yeah. 2/3 of the time it seemed to work, and then they were able to study them more electively. It is a strategy that would work in some of our outlying hospitals, and we do it already. I mean, we have hospitals that are just too far, and we give them thrombolysis regardless of whether they're 3 hours or 5 hours or 6 hours, anything less than 12 hours. We give them that, and then we send them over. And the 30-day event rate, death, shock, congestive failure, reinfarction, was pretty much the same with these two strategies. I won't spend much time on this. This is more the nuts and bolts of just what drugs do you give, the aspirin and clopidogrel. It is a best practice, unfractionated heparin versus enoxaparin. Some like, well, I don't like enoxaparin. I never know where I'm at. I like good old, plain old standard heparin. But guidelines say either one is good. And then when to send them on over. My personal feeling is, though, you know, it's not so simple. Just get them in the cath lab and open them up. STEMI is very much like a blind date. It is very much like bottom fishing, where you've got something on the line, but you know, oh yeah, that's a red snapper, that's a lingcod. You know, it could be a tire. You don't know till you bring it to the surface. And it's the same as responding to a 911 call. You know you have something, but you don't know what you got. Here's a young nurse that I took care of from our hospital who, I like this picture. When I stepped on the pedal, she still had her necklace on. And so it made a great opening slide. She had a 99 huge thrombotic proximal LAD lesion with a very angry looking EKG with huge STs and brief runs of unsustained ventricular arrhythmias, and things pacified out very nicely with emergent stenting. What lies beneath? She was a slam dunk. Scary, but easy, simple, straightforward. Suck out the clot, measure the vessel, put in a stent. You don't know what you got till you get in there. Sometimes you've got a tortuous, diffusely disease. Where's the culprit thing? How are you going to get there? Sometimes you got something like that. If you drag the slightest bit of clot back from that proximal LAD into the left main down the circumflex, school's out. You could have these ectatic, huge vessels, big thrombus burdens. They all look the same on an EKG. They show ST elevation. Okay, or you could have these shrivelly little things with an osteal left main, bifurcational thin diabetic vessels. That's part of the reason my personal preference is on people that get to me quickly. I don't give them Plavix till I know what the anatomy is, because often these people are going to go to surgery. If you give them Plavix in the emergency room and they're just going to be with me in 30 minutes, great. I find they got unsalvageable material by catheter-based strategy. Just about the time I have to send them emergently to surgery, the Plavix is kicked in at 4 to 6 hours and they bleed excessively. In the cath lab, I can give them a platelet inhibitor that works immediately. And if you get them there quickly, I don't need to have the Plavix ahead of time. Drug stents versus bare metal stents. This is an observational study. It would seem to indicate that drug-coated stents are better choices. So far, as I remember studying for the boards, there was no mortality advantage of bare metal versus drug in randomized trials. And one of the issues that we deal with all the time is you get an awful lot of people like this. I'm not putting a drug-coated stent in that gentleman. I don't trust him to take a year of uninterrupted Plavix. And the biggest risk to these folks is if they stop their Plavix early on, first several months, they're going to close it off and a large percentage of them die, as opposed to this lady who I guarantee is going to take it. She'll take her stuff. So you got to get all this history while you're kind of jogging down from the ambulance bay, doing a quick exam, when they can't even remember what their spouse's name is, okay, and they're going to tell you that, oh yeah, I don't have any bleeding, I have good insurance that'll pay for medicine, I don't have any upcoming surgeries, but I can't remember my wife's name, okay. So you got to make some snap judgments, but you try to make intelligent. So best judgment for that one. Radial versus femoral. Our younger colleagues are really good at doing the radial stuff. And certainly it's a technique that has advantages. It has some disadvantages, but it clearly is preferable in some folks. And studies that have randomized it with experienced centers do very, very well with it. Lower bleeding rates. A good groin closure unit as part of your team. I haven't transfused a patient in 12 years. So you can get groin bleeds and bruises go away, but I've never had to transfuse somebody in 12 years. Thrombolysis can sometimes work, but here's where we're using thrombectomies. And you can find data to support either thing, but the majority of studies would say that if you go in there just with a hollow tube and a big 50 cc syringe and suck out the clot, that works. It helps. If you go in with one of these mechanical rheolytic devices that creates tremendous suction, it does a beautiful job on the vessel, but they don't do any better. Now, the problem is the tiny little catheter isn't going to suck out a huge clot like you saw in some of those coronaries, and sometimes you have to have this in your golf bag as a trick. Intracoronary ReaPro, abciximab really doesn't work, and the Horizon study would indicate that under the vast majority of circumstances that the bivalirudin is probably preferable to combined heparin and 2B unless you have a huge clot burden, in which case you can always add a 2B 3A inhibitor. It's a best practice. Data drives change. You've heard that over and over. This is what I call our scattergrams. Karen Bales helps with these. These are very, very informative, kind of shows you how you're doing. You set that 90-minute limit. This is every case that you've done starting over time. And you can see the vast majority are under 90 minutes. There's always people that it takes longer. These are people that have mixed diagnoses, or you're, oh gosh, they had neurologic symptoms. I'm not doing anything till my daughter gets here. Anyone who says they do every one of them under 90 minutes, the data is not real. This is real life, okay? You can miss them, you can be slow. There's a number boy, I wish we were just about 2 minutes faster. We would have been good docs instead of bad docs. But the majority of them are doing very well by that strategy. Data management is key. Here's all of the de-identified doctors in my group. Every once in a while, Karen will crank out a little list here of how they're doing and compare it to the other doctors, and I share it with them. And the guy on the right, he suddenly gets lost in the middle is where he wants to be. He may not be able to keep up with me down there on the left, but he certainly doesn't want to be over there on the right. It's a best practice. Data drives change. Anyway, here's again, another picture of how things change over time, starting at 2003 at the bottom and all the way on up, and maintaining the gains as best you can. And then there are guidelines where when your patient leaves the hospital, they're going to be looking at you, whether you gave aspirin, beta blockers, and then if you had congestive failure, whether you got an ARB or an ACE inhibitor, how quick were you to give reperfusion therapies. Action registry data, like it or not, you're being graded. Well, how do we do in Oregon? Well, we had 3 out of 168 made the platinum and 1 out of 28 the gold, pretty much average for a number of states, and 1 out of 50 or so. We're doing okay, about average. So, and the health grades looks at you. Everybody wants to be that lead guy going over the hurdle. Look at how far ahead he is, okay? What the purpose of the systems response and getting everybody on board is so that almost everybody's clearing the hurdles. at the same time. And what you don't want to happen is that. And that's how the data will watch for it too. And you saw this. We're doing all right in Oregon compared to the East Coast and east of the Mississippi. Good is good, better is better. There we are up there. All of Oregon looks good, but if you go down to the deep south, my son was a med student at Emory, and he took this picture at a restaurant. It's a double bacon cheeseburger on a Krispy Kreme bun with tater tots, and deep fried fat Twinkies were for dessert. And then, of course, we're trying to still get the doctors to quit smoking, but that was an ad from the National Geographic in the 1950s. So one of my final slides here is STEMI therapy. The most stabilizing of STEMI strategies is the swift and safe opening of the infarct artery, and that's utilizing best practices. I want to finish with one case that I think will sum up everything that has been emphasized here today. When everything worked the way it should, the way that we want the system to work. Crater Lake, which is renowned for southern Oregon entertainment, is pretty remote. And there was this, that's kind of way up, well, here's kind of where Medford is, and there's Crater Lake, and there's two ways to get into it, the north entrance and the south entrance. And the north entrance is even more remote than the south entrance. It's really far away. You're talking a couple hours by car. And there was a young lady from your neck of the woods. She was a science math teacher, 52 years of age. She was down there this past August with the Boy Scout troop. Her son's a Boy Scout. And her best friend was the Boy Scout leader. And they were biking around Crater Lake, camping at Diamond Lake. And every time they came to one of the 5-mile hills, oh, she'd get nauseated and pale and chest discomfort. And about the second or third hill, her best friend said, I don't like the way you look. Left the bike, put her in the sag wagon that she was driving, and went racing to the north entrance. And right there was a highly experienced 18-year-old boy who was taking the money as people were coming in, and he took one look at her, and she was puking and was pale and said, we need help, and he called the park ranger. And the park ranger, of course, is up at the lodge, which is about 30 minutes away, because that's where the majority of people are. And he didn't like the sounds of it. He jumped into his rig, grabbed his medical kit, and grabbed the AED, and went racing to the north entrance. And about 15 minutes away from that, a guy said, she's really looking bad, at which point she promptly keeled over and dropped dead. And the boys, this is not her because we don't have actual pictures of that, but the Boy Scouts, her best friend and son and other Boy Scouts started doing CPR. There was a family physician in line, and they let them ultimately hold the IV. Okay, when the paramedics got there. The paramedic guy arrives, ongoing CPR, pulls out his AED. It takes 3 shocks of the AED to get a rhythm back, at least a barely palpable pulse. On his way, at 15 minutes out, he was feeling bad enough. Before he knew she'd had a cardiac arrest, he called Medford and had the Mercy Flights helicopter. And they love to do it because it's a no-fly zone over Crater Lake unless there's an emergency. So they were able to come directly in over the lake. Okay. So the Mercy Flights gets there and get the first EKG on scene, and she's got tombstone ST segments across the anterolateral precordium. This is bad. She's got a pressure of 60. They start pressors. They radio ahead. We'll be there in 23 minutes, which is the flight time. And my partner, Ken Dowderman, meets at the ambulance bay with the ER doc, and she needs to be intubated. And they rush her into the cath lab. They have to put on 3 pressors to keep her pressure at 60, put a balloon pump in, intubate her in there. She has a total of 12 electrical defibrillations between the first event and there. And then he gets the cath going. And so here's her picture. No big surprise, widower maker, proximal LAD. Okay, puts a wire across, puts in the little suck out whatever clot you can. All right, then deploy a stent. There's the stent, there's your LAD. Pressure starts to go up 70, 75, 80, still on 3 pressors. Okay, rush her up to the CCU. Institute hypothermia protocol, and the entire scout troop and family standing around because now for the next several days you're in the committed mode. You cool them down for 24, 36 hours, slowly warm them back up, and then wait. And on the fourth day, there she is. She comes back 2 months later. We had a big celebration for her. She played a couple rounds of golf, and then the American Heart Association had heard about it, and there's the entire team of people who were responsible. This is what can happen with a system of care when everybody does their job. Now, it doesn't happen every time like this, but it can happen. She's 52. She's back to teaching science and math. So with that, I think we'll take just about a 2-minute break. Don't disappear. We'll get the chairs up here, and we'll get ready to take some questions and field some stuff.